Cancer staging. The importance of a common stage language. Medicine continues to advance at a rapid pace. With more and more information coming out, this presents a conflict in the need for change versus the need for stability. One of the goals of cancer surveillance is to compare extent of disease across time. As mentioned in the previous video, for cancers with screening programs, there should be greater distribution of early-stage cancers at diagnosis versus cancers with no screening programs. In the context of screening, we also need to know whether the distribution of stage is changing. If there are different definitions of what stage is between two time periods, this change might be the result of a change in distribution, not due to an actual change in the extent of disease. This presents a conflict. With an increase in scientific and medical knowledge about prognosis and appropriate treatments, we want to modify definitions used in staging, but we also want to compare across time to assess if there are changes in outcomes. Ideally, we want stability in definitions that don't change with time. It is important to have a common language for stage classifications. For example, a study conducted by the International Cancer Benchmarking Partnership looked at the comparability of stage data, particularly on differences in survival in 6 countries with similar healthcare systems: the UK, Sweden, Norway, Denmark, Canada, and Australia. Results from the study showed that 1-year and 5-year relative survival were lowest in the UK and Denmark compared with other countries. This difference in survival may have been because patients in the UK were presenting later and with more advanced stage cancers. The next part of this study examined stage data to determine whether relative survival across the same stages was different. Unfortunately, only about 50% of cancer registries involved in this study collected stage data. Those who did used different staging systems, different editions of TNM, or different classifications to stage different cancers. For example, Duke's classification system was used for rectal cancer, and FIGO classification was used for cervical cancer. Norway and New South Wales used their own classification systems, which was different from both the TNM and each other. This CT PET scan shows a lung cancer directly invading the mediastinum. In the UICC TNM system, this would be staged as CT4N0M0, which is considered localized. But in the SEER, Local Regional Distant System, it is classified as distant. When the International Cancer Benchmarking Partnership used stage data, they were able to show that unfortunately, in the UK, for stage 4 breast cancer, the survival was significantly worse than for stage 4 breast cancer in other countries. It is important to have stage data, and it's important that the stage data that's being used is the same classification across all countries and guarantees comparability. For a list of helpful resources and publications on TNM staging, visit the UICC website, www.uicc.org/resources/TNM.